for entertainment, education, and information purposes only, and the topics discussed should not be used solely to diagnose, treat, cure, or prevent any diseases or conditions. Furthermore, the views and statements expressed on this podcast are solely those of those and should not be interpreted to reflect the official policy or position of any entity aside from possibly Cash Like More Hospital and affiliate outreach programs, if indeed there are any. In fact, there are none. Pretty much, we aren't responsible if you screw up. You should always do your own homework and let us know when we're wrong.
Coming into the show with a lot of energy. We just did a group clap. There's 6 of us here. We're doing our second recap from SGIM. SGIM, we kind of had this fight already.
We're still debating. Yeah, I think SGIM seems safest. Yeah, but the energy's palpable. The clap really got everyone going.
So I'll name everybody, and then you can reintroduce yourselves as we go around. But we have with us Shreya Trivedi, Carolyn Chan, Justin Berk, and Nora Taranto. And we are going to be just recapping some of our favorite pearls from the day, but maybe just for the heck of it, Paul, why don't you tell people about the show?
Sure. As you all know, the show in general, the Curbsiders, or what did you want from me, Matt?
Yeah, Paul, why don't you tell people what we normally... Paul, why don't you tell people...
One show that you've seen in the past
I'm so
year.
Tired.
Doesn't have to be medicine related.
The Battle of the Network Stars, it was wild. So it was these celebrities, and they would just do circus things. Like, they were just trained to, like, tame lions and walk on trapezes. Really, really fun. No one got hurt to my knowledge, and I'm surprised they don't do it anymore.
Okay.
So good stuff.
We
are the
lost.
Internal Medicine Podcast. We use expert interviews to bring you clinical pearls and practice-changing knowledge. This time around, we are your experts, and we are experts because we've been attending conferences and talks and workshops about various topics here at SGIM. And by we, I mean everybody else who's here. I'll just serve as backup cheerleader.
And I think we're going to start because the conference is still going on. We have some people that have to get out and go to sessions. So I think first up, we just got to go to our team, Shrebies, Justin and Shreya.
What up?
So Shreya, your mic was off, and let's pretend like you didn't just say what you said. So
this is the Internal Medicine Podcast. You expert interviews to bring you clinical pearls and practice-changing knowledge.
Oh my goodness. Okay. Justin and I, Shrebies, we were just talking about a clinical update I went to on career development. This is a new session that SGIM has this year, and there was 2 studies that I thought were really intriguing. Both were presented by Daniela Zipkin of Duke. And so, Justin,
I'm ready.
One of the studies, I want you to tell me what you think about it. Do you think generalists are better or worse than medical and surgical subspecialists in terms of academic productivity and getting to professorship?
You know, Shreya, I think that the generalists are the underdog in medicine. I think they are more prolific in getting grant funding and writing papers, but are not getting the recognition they deserve and are not getting the promotions that they deserve.
Yeah, so I think you're onto something. I don't think that that's fully the case. So there was
great unbiased opinion.
Yeah, great feedback. Yeah.
No, but super A++ crowd pandering. Yeah. So really strong work there.
All right, so this study, which I thought was cool in that back in 1995, there was a national faculty survey about 1,800 full-time faculty around the country, and followed them 17 years later in 2013 and said, hey guys, what is like the number of publications you've had? What's your faculty rank? The number of grants you've received? And in terms of the differences between a generalist and a medical or surgical subspecialist, there was no difference in receiving a federal grant in the last 2 years. So we're okay on that level. But despite that, in terms of academic professorship or publications, generalists are statistically significantly less in those regards. And so to just give you some numbers to wrap your head around, a generalist after 17 years has about an average of 44 publications versus a medical or surgical specialist has about 57 publications. And then in terms of getting to professorship, 53% of those professors, or 53% of those faculty became professors of the generalist versus 66% of the medical specialists or the surgical specialists became professors. So we are a little behind on that. And there's all these reasons that we could think of as to why. And I think this study's obviously limited in that this is from like back in 1995. A lot of things can happen in 17 years from those full-time faculty. But I think in terms of generalists, for us, publication doesn't always equate to scholarship I rephrase that. Scholarship doesn't always equate to publications. We are often doing other teaching roles and things that
Like podcasts.
Yeah, that's a whole new thing of how do we translate that into academic currency?
Or real currency as far as that goes.
All right, let's get on to the other paper though. Okay, Justin, this is a true and false question.
Ready.
Do you think GIM institutional leaders hold peer-reviewed publications as highly important for the development of a clinician educator?
True. Yes. I think that
Peer-reviewed publications are always the way to go.
I do think that they think that those are important, though perhaps should also be looking at podcasts and other more innovative forms of medical education dissemination.
Yes, new modes of delivery. Okay, so I think you said true, and it was a trick question. It's true and false actually. So this was a survey of about 130 GIM division directors in 2011, and asked them, hey, can you rank these various clinician educator scholarly activities from very important to not important at all? And so, yes, you're right in that, like, combined relative to all the ones that were on that list, peer-reviewed publications did make it to the top. However, what I thought was compelling is if you looked at the data a little bit more, and you looked a little closely, there was actually a polarity between the GIM division directors. So about 48% of those division directors did say, yeah, this is very important, peer-reviewed publications. But 46% of those division directors said this was not important. So my takeaway is that basically there's a split of GIM directors in when they think of a clinician educator, thinking about how important a peer-reviewed publication is. So I think the takeaway for listeners should be like, hey, know your division that you're in and know that culture. Or if you're looking for a job, kind of seek out what those expectations or cultures are.
So the publisher parish is only at specific institutions.
Only at 48%. No,
Got it. Got it.
Yeah. So
publisher parish is my strategy for Twitter and Instagram.
I just love how you're plugging the digital modalities
I'm in a social
of
media
scholarship.
mood today. I'm wearing a Curbsiders t-shirt.
Yeah.
I'm really feeling in the role.
Justin, what did you learn today?
I had a quick side tangent, Shreya, not to just avoid the question, but on our Twitter, it said the Curbsiders will be wearing red t-shirts today. Please come and say hello. And someone came and said hi and said, you are from the Curbsiders? And I said, yeah, I have the Curbsiders t-shirt. She said, I just went to someone else that was wearing just a normal red t-shirt and they had no idea what I was talking about. So that's a shout out.
The plan works.
The plan works.
Like I am Spartacus, kind of the same thing, right? We're all really curbsiders when you think about it.
So I won't take too much microphone time, but I think a couple of things that I thought were worth mentioning. There was an update in addiction medicine session that I have a lot of passion about. A lot of the studies we've talked about, but I think a couple pearls that came to mind were worth resharing. One was this Annals paper by LaRoche in the Massachusetts study. It was on hotcakes, it was on the ACP, but really emphasized that the 12-month risk of mortality in opiate use overdose patients that have overdose but did not get treatment was 5%. So about 1 in 20 of these will die within a year. That being said, only 30% are actually getting treatment. So again, a real missed opportunity to get patients the care that they need with medications like buprenorphine.
Justin, what do you think about buprenorphine requiring an X waiver? You think that'll ever go away?
I am so glad that you asked that question, Matthew. The X waiver is, I think, an antiquated legislation that makes it so that in order to prescribe buprenorphine, in order to prescribe life-saving addiction medication, you have to go through this 8-hour training to get a waiver. Or for nurse practitioners and for physician assistants, it's 24 hours. This is a huge amount of time, especially for these frontline providers, right? So there is a slow movement of buprenorphine deregulation, and in fact, a representative in New York, Representative Tonko, recently proposed a bill, the Addiction Treatment Access Improvement Act, that would be trying to increase access to life-saving buprenorphine by avoiding the buprenorphine waiver requirement and allowing all providers to offer this life-saving medication. And this was brought up, and I think this is something that more and more people should get to know about and hopefully support.
Yeah.
But Justin, do you think that's safe I mean, isn't buprenorphine probably a dangerous medication?
Such a great question, Paul. And I think this is one of the major concerns of a lot of providers. Buprenorphine has been demonstrably effective and safe in countless studies. And when you think about it, it seems a little silly that I remember as an intern on my first day, I was ordering IV morphine and prescribing, large amounts of oxycodone potentially. Pretty much unregulated. But yet I'm unable to write buprenorphine for addiction, addiction treatment, a much safer drug that has a ceiling effect, that has much lower chance of any kind of respiratory depression, has much lower chance of any type of overdose. So a very safe medication with wonderful data to support it. I think this is something that is coming into its own, and the future is going to be in buprenorphine treatment for addiction.
Should we go to Carolyn? I think you had some other pearls about bupe as well.
Yeah, absolutely. So I went to this wonderful talk called Buprenorphine 2.0 that just sort of focused on additional ambulatory management of folks with opioid use disorder who are receiving bupe. And I think one of my take-home points from there was that stimulant use is not a contraindication to buprenorphine. Mm-hmm. I think that sometimes folks come in with, positive cocaine. That does not mean you need to stop buprenorphine. We're using this drug to treat the opioid use disorder. And there's really no medical consequences in terms of them truly interacting for it to be a reason to stop.
And you shouldn't punish the patient because they have a substance use disorder.
Right. And they sort of talk about doing a check-in, talking about it openly, using open-ended questions to not ignore it, but sort of reassess and maybe offer additional resources, have them check in with a social worker, see if they'd be more appropriate for another sort of counseling, IOP. So I thought that was great. Another pearl that I thought was really helpful was buprenorphine during the perioperative period. As a hospitalist, this always makes me nervous. What do I do? Do I switch to narcotics? Do I keep them on the buprenorphine? And the answer is really either or. So you could either sort of taper and then use opioids to sort of bridge, or it's completely okay just to leave the buprenorphine on. You can even split the dosing to TID or QID, and that can actually give you some analgesic relief. So I think for me, that's more practice changing is I'm probably just going to keep people on the buprenorphine and split to TID dosing unless I think they're going to need extraordinary amounts of control.
And the guidance I've been told is you can still prescribe short-acting opioids on top of buprenorphine. You just probably have to use much higher doses.
Right.
Exactly. Yeah. And they sort of
so I don't have a ton of experience in that situation yet, but the 4 times a day dosing should have some pain effect because I think it lasts 6 to 8 hours per dose. So
exactly. Yeah.
Justin, anything else from addiction medicine?
The only thing that I thought was cool, they talked a little bit about transitioning individuals from methadone to buprenorphine. They had a case example of someone who has a prolonged QTC and wants to go over to buprenorphine. And the basic pearl was that you want to get the patient down to methadone dose of between 30 and 40 ideally.
Okay.
So you would have to titrate down their dose for about a week. Then you would stop the dose for about 72 hours before you would then start someone on buprenorphine. That being said, it sounds like there's some data that maybe you should do it at a higher dose. And one of the more innovative treatments that people are talking about is using either microdosing of buprenorphine or the Butrans transdermal patch. Yeah. So having someone on a methadone, even kind of higher dose, so something like 60 milligrams, starting the transdermal patch, and then you should just start buprenorphine the next day. And the idea is that the transdermal patch is given a small enough dose to kind of prevent withdrawal and push them off. Correct, exactly. And so I think this is there's more and more evidence for how to do this. Another great resource in Pearl, Carolyn, I don't know if you had known about it. I had never heard about this, but UCSF has something called the Warm Line. You can Google UCSF Warm Line, and it's a free telephonic consultation service Monday through Friday at any time that you can just call and say, hey, I have a patient on methadone that wants to go to buprenorphine. How do I do it? Or these are challenges. Amazing. It's such a great resource that I didn't know anything about.
I like how they call it warm line. There needs to be more warm lines in this world.
Yeah.
On this topic.
That's a great quote. The world needs more warm lines.
All of a sudden, all these warm line 1, warm line 2. What do all these mean? Positive things. Yeah.
In one of the plenary sessions, Michael Inksay from UCSF was talking about there is a free waiver available now for buprenorphine at pcss.org. That was news to me because I know when my institution, Cashlack, when we got wavered, it was $200. So you can get a free waiver. So that takes away. Now it's just a time barrier instead of a cost barrier to get your waiver.
think that organization, it's a fantastic organization that I'm not remembering what the PCSS really stands for, but they offer mentorship as well in terms of actually starting. Like there's a lot of free resources, a lot of education on their website. So it's, in addition to the training, it's a great resource all the way around.
The Providers Clinical Support System.
All right.
Nora just pulled a Stuart and looked something up in the middle of.
He's trying to take his place.
Thank you. And they have 3 books left.
Now,
We expect puns later, Nora.
Nora, we haven't heard from you yet. I know Carolyn has a little bit more, but Nora, why don't you talk a little bit about? I think you were going to talk about young adult medicine.
Yeah.
Or am I using the right early adult? I don't know.
Young adult is great.
Young adult. Okay.
Yeah. So I went to the update in young adult health and young adult medicine. And there were a couple different interesting updates from the last year or so. I guess I'll start with.
Well, could you define that first? Because like when I heard that, I was like, "Wait, is this like a med peds thing or?"
So it's mostly about patients who are above the kind of 18 threshold and are transitioning to care with an internist or a family medicine practitioner.
Okay. Newly minted adults.
Exactly. And so I guess actually I'll start with the transitions of care guidelines that were released last year. And you can find them. They were published in Pediatrics and were authored by a couple specific folks and then kind of co-authored by the AP, the AFP, the ACP, so kind of all of the societies for the different stakeholders. And the report was primarily a literature review and expert opinion about kind of how to best facilitate the transition of care from pediatric practice to adult practice in whatever form that is. And so one of the takeaways that I thought was the most important was this recommendation and reminder to practitioners not to assume that young adult patients know how to navigate the healthcare system independently, which I think is pretty profound and relevant. I think when we think of young adults, we often think, oh, they're very competent. They are now adults, and they know how to use technology, for example. And so they must know how to navigate this healthcare system, when in fact, oftentimes it will be the first time that they have had to navigate it independently. Sure. And they may not actually know how to have a conversation with their doctor. So I thought it was a very...
Did they give a way, like a practical way to kind of overcome that?
No.
Okay.
They did recommend that you have kind of young person friendly interfaces and allow for patients to email communications, have patient portals that are more technology friendly. So I think that's kind of one slightly indirect way of doing this. And then also having documents that are basically checklists for patients and their families to make sure that you're not missing anything and that they're not missing anything, and the steps to do to get enrolled at your clinic, that sort of thing. So those are kind of two pieces of it.
Not so much in terms of warm handoffs. I think we talked about this a little bit in our sickle cell episode, but not a whole lot of role for sort of talking to their pediatric doctor.
Some role for that. And in fact, they were recommending that pediatricians often should be seeing the patients until you've done the handoff, but no explicit language or questions to ask the pediatrician. I think a handoff can never hurt.
Okay.
Fair.
Without a doubt.
And you were telling us that there's a couple kind of chronic conditions that you, or just kind of disease-specific things that you wanted to talk about in this population.
So I'll go through them relatively quickly. So childhood kidney disease, which encompasses a bunch of different things. It can be as simple as pyelonephritis, or it also includes congenital kidney anomalies, which a number of children have. And there was a study published in the New England Journal last year about how these childhood kidney diseases affected kidney kidney function later on,
Right.
and the risk of developing end-stage renal disease, and found that the bucket kind of across the board, childhood kidney disease, did actually put people at increased risk of developing end-stage renal disease and also developing it early, lower than 40, pretty dramatically.
Which means we probably should be screening for that in young adults when we're seeing them in clinic.
Exactly. It would be very appropriate to ask on an intake exam, do you have a history of kidney infections or any sort of kidney disease as a youth?
So on a related topic, what if their blood pressure is like 134? Do I care about that?
We do.
Okay.
There were actually 2 studies. That was a great transition.
Thank you. I've been doing this for a while now.
Yeah, no.
So there were 2 studies in the last year about the 130 to 139 systolic range. And there's a new definition by the ACC-AHA labeling that as stage 1 hypertension. And what to do with that in general, but specifically in young adults, had been kind of up in the air. And so there were 2 studies in JAMA published last year that looked at the risk of cardiovascular mortality and just cardiovascular disease in patients who had stage 1 hypertension as young adults.
Right.
And they concluded that actually having stage 1 hypertension when you're younger does pose significant cardiovascular health risks and overall health risk to patients. And then a second follow-up study actually looked at intervening on the stage 1 hypertension and treating it, and found that could mitigate the cardiovascular and health risks almost completely.
Yeah.
So suggests that we should
speculate,
be treating earlier.
Paul, doesn't to me that would be like, I just wonder if these are like people who are not, they're stressed out, they're overweight, they're not exercising. Maybe it's a marker of just overall morbidity.
I feel like we're practically married now because I think you must have been reading my facial expressions. Like I was sitting here in pain looking constipated because, I wonder if that's not a marker for sort of other comorbid conditions. I think that's exactly right. Either at-home stress or elevated adrenergic levels for whatever, or more commonly obesity. And if you intervene on those things, I wonder if you would mitigate the same effect. I'm not sure if they stratified out that or not, but that would be sort of my gestalt. I hate the idea of treating it at that young an age for like 131 systolic. That just kills me.
I mean, it would just seem practically that if you couldn't see a modifiable risk factor, then maybe you would be stuck treating or at least having a conversation about it.
Yeah, especially if you get a background of family history that's significant or other mitigating factors. But just if there's other stuff going on, you have a better explanation that you could intervene upon. I feel like that'd be my preference because more often than not, it'll be lifestyle and diet and modification of other things that are not necessarily involving lifelong pharmacologic therapy.
Yeah,
which is what we should be doing in the first place.
Right,
is like really, I think that like the young adult is the perfect patient to really encourage early on. Like, make these lifestyle changes now. How can we help you with this? And it can really change someone's trajectory. Like, we should be doing it more at this point in the game than when we're in, my patient in the 60s who I'm like, okay, all right, I'm going to keep doing my diet. Yeah.
I'm so sorry for interrupting. No, I saw that study and I think I cheerfully ignored it just because I really did worry it was going to be a mandate to not just go ahead and throw medication out rather than have the hard conversation. So anyway.
Yeah. So the other thing I know you want to talk about is the HPV vaccine, because when I think of young adults, I mostly think of like, sexually transmitted infections, like substance use, accidents, things like that. I wasn't thinking of the high blood pressure, but what's the latest on the HPV vaccine?
A couple updates. So the one latest update in the last year, the HPV-9 valent vaccine was approved by the FDA for use in adults who are 27 to 45. There have not been guidelines released on whether or not we should be giving it to that age bracket. It is currently recommended for females who are 11 to 26, and then males who are 11 to 21, and then 22 to 26 in certain high-risk groups. But but the kind of extension remains to be seen. The society that recommends that will probably be speaking on it at some point in the next year or so.
And we talked about this yesterday on our LGBT episode, and basically they were saying that it's a problem getting it covered for patients that are older, but it seems like that's the direction we're moving, or people feel like that's probably the right thing to do.
Yeah, and we had an interesting conversation that didn't actually resolve in one specific answer about whether or not people who were vaccinated with the HPV-4 quadrivalent vaccine should be receiving
upgraded?
Added kind of revaccination with the 9-valent.
Sounds
Jury's
like the
still
pneumococcal,
somewhat out about that. Yeah,
there's 2 pneumococcal vaccines. We're giving both of those, so it seems like a similar.
Unfortunately, yeah, because the algorithm has destroyed many a resident. So, the less complicated, probably the better off will be for
That's
everybody.
true. That's a good point. But the study that came out about the HPV vaccine efficacy revealed that it is effective in HPV vaccinated groups, and then also provides a decent amount of herd immunity in unvaccinated adults and youth, which is important because we still actually don't have great uptake on the vaccine. Among females 13 to 17, only 63% had one dose, according to kind of the latest data, and then 42% had all 3 doses. So.
Yeah, it's a shame that it's a vaccine that prevents cancer, and that there's some social issues with, or there's some bad press about parents thinking that means their kids are going to become sexually active at age 11 if you vaccinate them, which I just think is kind of unfounded. I think it's ridiculous.
Totally. Yeah,
I did just see the first male targeted ad on TV for the Gardasil, or the HPV vaccine.
Yeah.
It's real dark.
It's dark. It's really dark. But it was the first that I'd seen, because I remember right when it came out, I was in that targeted bracket, and it was much cheerier and much more female targeted for the longest time. And so this was the first one I'd seen.
Okay.
It is pretty dark.
Wow.
All right.
Yeah.
How are we doing time-wise, Paul? Do we...
Half hour in, at least that's how long we've been recording.
All right. Why don't we go to Carolyn? Carolyn, what else did you have for us today? I understand you gave a workshop. I wanted to hear. I didn't get to make it to that, so give me some pearls to catch me up.
Yeah. So I helped run a workshop today with my colleagues, Dr. Sally Nambudiri and Dr. Tamika Campbell. They've just done amazing work at curriculum development for residents in terms of resident mistreatment. What happens when residents are mistreated by their patients in particular? Because I think this is so challenging, right? Patients are a vulnerable population, but also residents are vulnerable as well. And they looked at a lot of the data, and they were sort of seeing that, if residents are mistreated, it increases their rates of burnout, which is super important sort of in the healthcare system and as they go along in their career. So I thought what was really helpful about this session in particular is that they gave specific language. And actually, a lot of this research has been done in the physical therapy world. So I think they're a little bit ahead in terms of how do we manage this with our patients. So in regards to sexual harassment, one of my favorite sort of phrasings that we can sort of use is this concept called I think, I feel, I want. So an example from that would be, I don't think you meant to upset me. I felt angry when you commented on my body, and I want our relationship to remain professional. And they did a lot about how just sort of having a standard go-to in your head can sort of prevent that freezing moment. Because I can think back of when I was a new intern and patients would say inappropriate things, I didn't know what to do, right?
Right.
You just feel
no one
stunned.
tells you. No one tells you, right?
Right. In some way, it's never appropriate for anyone to sort of harass, but in some ways it's if it was someone in the hierarchy, I feel like when I was in training, I would know how to manage that better than when a patient did that. And I feel like from personal experience, patients harass at higher rates, at least in my institution, than the faculty. Another really good line that they give was this concept of active listening and broken record. So an example would be, it's unfortunate that you feel like I led you on. I need you to stop commenting on my body. And if they come back again, then you keep repeating it. Like, I understand that you did not intend to upset me, but I need you to stop commenting on my body again. Just to like really draw that firm line. Don't ramble, and just sort of like give that concrete statement. And then the third and final example that they gave was like a positive negative warning. So if you stop trying to touch me and comment on my body, I will stay and help you. And if you continue to try and touch me and make these inappropriate comments, then I will leave. So I think sort of having those three sort of phrases in my repertoire has been like very helpful.
Yeah. Yeah. Thank you for sharing those. Yeah.
And the workshop itself was part of it actually just saying those things directly, actually saying them out loud. I think Abby Spencer was talking a little bit about something similar yesterday where it was just helpful to actually have to, even though it's sort of challenging to do so because it kind of, but actually being forced to sort of say the words.
Yeah, we did. We had split them up into groups and we did different cases. So one more sexual harassment and one more like racial bigotry. So we got to hear from each other and learn from each other. You know, what do you do? What's your phrasing? Because I don't think that there's any, there's nothing that's perfect, right? You got to have some tools depending on the context of what to do. I think something that was really interesting that they brought up is, you know, when a patient is being sort of just racially insensitive, when do you decide to transfer care to another provider was a really complex thing that we discussed.
Was there an answer? Like
it's complicated. Yeah, it depends on the situation, right? Because we don't want to reward that. We don't want to reward inappropriate behavior. We don't want to say, oh, you know, I only want to see white physicians. We don't want to reward that and just transfer to another, you know, white physician. So depending on institutional policies, I know the policy where I'm from is that we don't transfer based on sort of race alone. So usually it's like a multidisciplinary sort of approach. Sort of you go in, you discuss. If it's the intern, you sort of have a discussion outside the room about where to go and what to do. The preference being not transferring care. But there are circumstances, you know.
To a point, you have to protect the physicians and the trainees too from being in hostile situations. It's tough.
Did you have anything else? I had one or two random things from yesterday that I sort of left over that I wanted to go through. But anything else before?
Yeah. No, I think that those are like my big take-home points. It was another great day at SGIM. That's how we're saying it.
You're in the SGIM camp.
All right.
Okay.
Feels like a real
I think I'm
sound.
SGIM also.
You're SGIM?
Yeah.
Okay. I've been saying SGIM, but I mispronounce most things.
SIGM. Fine. I'll be contrarian.
Okay.
That's cool.
Well, Paul and I went to, I had to support my good friend Paul Williams, medical cannabis. They were talking about it yesterday. I think Pipe Dream was in the title. Mm-hmm. There was a lot of great faculty there. And they were talking about kind of the big take-home points for me were that medical cannabis, there's still more unanswered questions out there than answers. And you should be careful with it. But there's not a lot of identified risks. The main risk that I would identify is patients should know that they're going to be impaired if they're using it and driving. I know there's a whole thing about psychosis, but I think that, maybe that's just selection by, or, people self-medicating. They were going to become psychotic anyway. I don't know. But for pain treatment specifically, which was what the cases we were going through were talking about, they said that this should be really a late resort, not necessarily a last resort, but patients should have tried other things first, like non-pharmacologic therapies and the basic analgesics. And if all that's failing, then you might consider this. Medical cannabis really has the most evidence for neuropathic type pain. The evidence is very weak for MSK pain. Paul, can you talk about the certifying process and some of the pearls they were talking about there?
Yeah, I feel like it always, where we get a little bit tripped up is that we don't prescribe, we certify that someone's appropriate for it. And you can sort of specify ratios between CBD and THC. I'm not sure all prescribers, and prescribers is maybe not even the right term, all certifiers even have comfort with that level of specificity. So generally what happens is you give the patient certification and then they go to their bud tender, a term that I really struggle with. And then at that point, they can then help select a product that might best suit their needs. But some of the issues that you run into is this is not covered by any insurance. So all this is out of pocket. So it might be cost prohibitive. So for people who are resource limited, it's probably not the best possible option. And then I think some people struggle with just the fact that you are not prescribing, you are certifying, so someone can go out and sort of whatever happens after you give that certification can kind of be up in the air. But I think one of the things that I found helpful in this particular workshop was the idea of actually you can restrict your certification to a period of time, say 3 months, so the patient can come back and then reassess, and you can talk about efficacy and if you need to modify the plan or not. So you can have some control and feel like you're part of the patient's therapeutic plan, as opposed to kind of just so you're sort of setting them loose out in the world.
And a couple things about to follow up to what you said, it's a cash only business for the medical cannabis. So if you want to send someone to a bud tender, they have to pay cash right now. It's not covered by insurance. It's actually cheaper for patients to buy cannabis on the street. The problem is that can have all sorts of things, other things. The presenters were talking about K2 and whatnot. So it's not. We don't think it's safer. So one presenter was making the point, I'd rather have them go get the medical cannabis where I at least know where they're getting. As far as dosing goes, most in general, they think that a 1-to-1 ratio of THC to CBD might be, that was I think like the starting ratio, or probably the most common one that's used. And I think there's some formulations that specifically have that. THC having more of the sort of like like the CNS effects, the ones that you typically associate with smoking marijuana. And then CBD seems to be maybe more nicely balanced, where it doesn't have those effects, but it does have some of the pain effects that you're looking for. And so they said, there's formulations of that are available. But if you're going to use the THC only products, they suggest starting at 2.5 to 5 milligram doses. And I think it goes up to a 10 milligram tablet is the highest dose, they said. And I also learned that one joint has about 60 milligrams of THC, and one hit has probably about 10 milligrams of THC. So that's just to kind of quantify that for you. This is going to be a rapidly evolving area, so that's pretty much all we can say right now. So kind of like stay tuned.
I think one of the presenters actually made the point that they just found a CBD receptor like 10 years ago. Like this is not...
Yeah.
Like we're still in the frontiers. There's
more than 100 cannabinoids.
Yeah.
So, and if you want more on this, we did do an episode on medical cannabis a while back. I actually don't remember the number, surprisingly, Paul, but it was a good one. So you could go back and listen to that. Anything else, Paul, before we wrap up here?
No, I think when the updates in addiction medicine, I think something that I don't recall if we ever talked about on the show was the one meta-analysis that was done with alcohol use. I feel like there's always some debate as to what level is protective, and there's always some hint as maybe if you just hit the sweet spot of the J-shaped curve, you got mortality benefit or at least decreased cardiovascular outcomes. Because we know that a bunch of alcohol is not great, but maybe a little bit is kind of helpful. And then we always sort of hedge our bets, but don't counsel patients to drink for cardiovascular risk reduction, which is, I think, wise advice. But there was just a recent Lancet, I want to say it was a meta-analysis that looked at a bunch of data sources on alcohol consumption, and then looked at exposure and then risks of health hazards. And basically, there's this monotonic increase in adverse outcomes starting at 1 drink per day. So even 1 drink a day is associated with worsening outcomes. Obviously, the more you drink, sort of the more bad health outcomes that you have. But it looks at least... if you collect all the data sources and aggregate the data, if you look at it, that really no amount of alcohol consumption, or at least routine alcohol consumption, is safe. So I thought that was interesting, at least. Yeah.
And again, this is observational, so maybe that's just selecting for other risk factors. So it's not necessarily a causal relationship, but probably don't drink if you think you're doing it just to benefit your health. Like if you're not drinking already, maybe that's just stay away from it.
I think, because I don't think it's that long ago. I feel like I even heard my parents, well, actually, one of my parents' old doctors told them that it was okay to smoke a cigarette or two a day because it made you sort of regulate your breathing. And this is like back in the days, like smoking on TV while you're trying to diagnose stuff. But like, I don't think that we should be prescriptive and say, well, how about a glass of wine to reduce your cardiovascular risk? That seems like a genuinely bad idea.
I always wonder, like 50 years in the future, what are the doctors going to say? Like, I can't believe that they were doing that. Like, oh wow, what a terrible idea.
I mean, even now, as we're sort of peeling off aspirin, which just it seems so safe on the face of it, and we actually know it just has a bunch of bad outcomes. Like, it's all the stuff we do, we're still constantly reassessing, which is kind of one of the joys of medicine, but also one of its frustrations.
Yeah. So I think that's a great high point to end on,
sure.
Paul.
Yeah, I'm going to the law. Tired of this.
And so we will be back next week. We'll be back with full shows, and we recorded a bunch of full episodes at SGIM, SGIM,
Howard.
SGIM. And those will be coming out probably sometime in June, so look out for those.
This has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
Yummy.
When I just randomly point at you, you didn't know that?
No, I was like,
I totally set you up. Okay.
Get your show notes at thecurbsiders.com/podcast and sign up for our mailing list at thecurbsiders.com/knowledge food to get our weekly show notes in your inbox.
And we're committed to providing you with high-value, practice-changing knowledge. So we always love to hear your feedback. Send an email to thecurbsiders@gmail.com. We'd always like to thank our team that was here, Nora, Carolyn, Justin, Shreya, and to Hannah Abrams, who has been like remotely somehow tweeting this meeting, and to Chris the Chew Man Chew and Beth Garbatelli. Thank you for all you do. Until next time, I've been Dr. Matthew Frank Watto.
I'm Nora Taranto.
I'm Dr. Carolyn Chan.
And we'll say our sweet goodbyes on behalf of Justin Berk and Shreya Trivedi, and I remain Dr. Paul Nelson Williams. Thank you and goodbye.
Shrabies has left the building. One, two, three.
Super solid stuff. It's
So,
Should we do it again?
Group morale, yeah.
not that fun.
Ready? Great.